So in this session, we'll discuss the risk stratification and perioperative medical management for patients who are going for non-cardiac surgery. So first, I would like to introduce our panelists, and we'll start with Dr. Vashish again. I've known Dr. Vashish personally for at least 4 years as my mentor and as my teacher. Dr. Vashish has served on several committees, including the task force. He has been involved with the certification board for nuclear cardiology. He's been nominated twice by ACC to be on the board of directors for the CBNC. He's a chair for the ethics committee and a co-chair for the examination development committee for CBNC. So please welcome Dr. Vashish. Our next panelist is Dr. Dawson, whom we all know again very well by now. Dr. Dawson is board certified in nuclear cardiology along with several other certifications. If you have walked into her office, you'll realize she has got so many certificates. All the walls are covered with just the certifications. She has also written a chapter with Dr. Handel on exercise stress testing, which has been published in a handbook of nuclear cardiology. So please welcome Dr. Dawson. Now I would like to call our speaker, Dr. Shoaib Akbar. Dr. Akbar is one of our stars. He did his internal medicine residency from University of Minnesota and then went to University of Louisville to do his general cardiology, followed by interventional cardiology training. He also is boarded in nuclear and echocardiography along with several other board certifications. Presently, he is working at WKHL and is serving as the director for the director for non-invasive cardiology and associate director for interventional cardiology. Please welcome Dr. Shoaib Akbar.
Thank you, Dr. Singh. I'm going to be talking about perioperative cardiac risk stratification for non-cardiac surgery. And as a cardiologist, this is a topic this is an area that is close to my heart because it involves so many of us in the healthcare field as cardiologists, as primary care providers, nurse practitioners, nurses. We all take care of these patients, the surgeons and anesthesiologists. So I thought this would be a good topic to go over, especially given the recent guidelines. I don't have any relevant conflicts of interest. So the outline of this talk is going to be to try to learn to estimate the risk of perioperative cardiac events, to review the most recent guidelines from ACC/AHA released in December 2014, to improve the understanding of antiplatelet management around the time of surgery, to learn about evidence-based medical treatment for these patients perioperatively, and we'll have a case discussion at the end. So the aim of this talk would be to see if I can encourage you to think about these patients in a certain methodical manner. And if I can do that at the end of the talk, my job is done. We want to start always with the patient and their clinical risk factors, because those clinical risk factors lay the background risk for these patients. Next, importantly, comes their function status that has a huge bearing on their outcomes. And then the type of surgery that the patient is having also makes a big difference. Going further down, we have different tools at our disposal that we can use to risk stratify these patients further, and we can manage them accordingly. So the use of risk calculators is actually a Class 2A recommendation by ACC/AHA. And we have two well-established risk calculators, and I'll go over them, both of them, one by one. So we are familiar with the Revised Cardiac Risk Index. It's a validated tool over many years, and the utility is that it only has a handful of variables that you need to put in. 5 of those are patient-related. If somebody has history of known coronary artery disease, congestive heart failure, stroke, chronic kidney disease with a creatinine of more than 2, or are insulin dependent around the time of surgery. And 1 is related to the actual procedure itself. Each aspect gets 1 point, anybody who has more than 1 point is a high-risk patient. And the risk of the surgery and the risk of MACE, which stands for Major Adverse Cardiovascular Outcomes, goes incrementally as the number of risk factors go up. Now, the new kid on the block in terms of risk stratification is this American College of Surgery National Surgical Quality Improvement Program calculator that came out in 2011. This has turned out to be a fairly useful tool. It incorporates more patient-related clinical findings, and it's based on more than 1 million surgical procedures performed across the United States. It has been shown to outperform the revised cardiac risk index in discriminative power, especially in terms of high-risk surgery like vascular surgery. And in addition to just MACE outcomes, it also gives us an estimation of the risk of pneumonia, DVT, length of stay. So a little bit more exhaustive calculator, but there are online tools where you can plug in these numbers, but then it gives you a lot more in terms of the potential outcome and predictors, length of stay, serious complications, pneumonias. So this is, again, a very useful tool. Now, function status has long been proven to be a reliable predictor of long-term outcomes and perioperative cardiac events. And when we are risk stratifying these patients, patients who can perform activities of more than 10 METs are generally classified as excellent function status. Between 4 to 10 METs are intermediate function status, and anybody who can't even do 4 METs is low functional status. Now, this is just a few daily activities of daily living, and if we get a good history from our patients, it helps to risk stratify them. So anybody who's doing simple housework, light housework, they're just doing 2 to 4 METs of activity. Heavy housework is 3 to 6 METs of activity. They listed sexual intercourse with an established partner, 3 to 6 METs. I don't know if it's different for a not established partner. I think we are waiting for data from Ashley Medicine, and we'll update it as soon as possible. Next, the type of surgery the patient is undergoing also makes a difference. You put the patient and the surgical risk together, and you find out if the risk of MACE is less than 1%. And if that is true, then they are low-risk patients. Examples would be somebody going for a cataract surgery or plastic surgery. With the new revised guidelines that came out in December 2014, they have taken away the intermediate risk category. The reason for that is any patient who has more than 1% risk, and whether they were intermediate or high risk, they are managed the same way. So kind of they got rid of the redundancy and made it simpler as low risk and high risk surgery. Adding emergency to a procedure obviously adds on to the risk of this procedure. And if you can do a procedure less invasively, that lowers the risk. In terms of timing of the surgery, they are labeled as emergent if we have only 6 hours, otherwise life or limb is threatened. This leaves little time for evaluation. An urgent surgery gives us a little bit more time, but still not enough, up to 24 hours. Whereas time-sensitive surgeries are those which are anywhere between 1 to 6 weeks you can wait, and most of your oncology surgeries would fall under that category. Whereas elective surgeries are those that you can wait for up to a year. Now, we've gone over, and you'll probably come across these different guideline recommendations, so I'll just go over them to make it easier for us, for those of us who are not familiar with it. So when we hear about classification of recommendations, Class 1 recommendations are those which have solid evidence behind them, and they come with a strong recommendation that doing that intervention or treatment is good for the patient and is recommended. When the evidence for benefit is less obvious, it's a Class 2 recommendation, which is further split into 2A or 2B, depending on how much the weight of evidence is. If it still looks like most interventions are helpful or data is supportive, it's 2A. If the data is not so robust, it's 2B. Whereas Class 3 recommendations are for those interventions that are not recommended because they've been shown to be ineffective and potentially harmful. The level of evidence A, B, or C signifies what kind of background data supports that recommendation. Level of evidence A is the strongest. It means multiple randomized controlled trials have been done, multiple populations have been studied. Level of evidence B usually means at least one randomized controlled trial, whereas level of evidence C is based on expert consensus. So these are the guidelines that came out in December 2014 and were published in circulation in Journal of American College of Cardiology. And it's an algorithm, and we'll go through it step by step. So the step one is you want to evaluate your patient and figure out if they have underlying coronary artery disease or any significant risk factors. Next step is to figure out if it's an emergent surgery. If the surgery is emergent, then you really don't have a choice. The patient has to go for surgery, and you manage them post-operatively. However, if it's not an emergent surgery, you try to figure out if the patient is having an acute coronary syndrome. And if that is true, you manage these patients according to the guideline-directed medical therapy. If that's not true, then you move on to the next step and figure out what is the risk of these patients going for the surgery. And if the risk for the surgery is low, which means we expect the major adverse cardiovascular events to be less than 1%, it's actually a class 3 recommendation to do any further testing, which means these patients can just go ahead and get the surgery done. However, if the MACE risk is more than 1% and we are dealing with a high-risk patient, then you want to assess them functionally. How much can they do? Can we get a good history from this patient? Anybody who can do more than 4 METs of activity can proceed with surgery without any significant risk stratification with a stress test or an echocardiogram. However, we do come across a lot of patients in our practice, patients who have morbid obesity going for a bariatric surgery, patients with severe COPD or orthopedic issues that limits our assessment of them in daily living. So if we don't know their functional capacity or we know that they have a poor functional capacity, then it is actually a 2A recommendation to proceed with pharmacological stress testing and then proceed from there. If the pharmacological stress testing is normal, we'll go to surgery, but if it's normal, then you follow the clinical practice guidelines that are already established, take them to the cath lab, intervene if needed, medically manage, go from there. So, but if the stress test is normal, you proceed with surgery. This is again the algorithm. Now, let's briefly talk about some of the supplemental preoperative evaluation tools that we have. So we have the EKG, the assessment of LV functions, usually with an echocardiogram, exercise testing, which I've alluded to mostly in that algorithm, and there are some special situations. So these are recommendations from ACC about which patients should get these tests done. So it is reasonable to do an EKG for somebody who has known coronary artery disease, known significant arrhythmias, known cerebrovascular disease or peripheral vascular disease, except if they're going for a cataract surgery, except if they're going for a very low-risk surgery. You don't need to get an EKG. However, same thing if somebody doesn't have a prior history of any cerebrovascular disease, but they are going for a non-low-risk procedure, it is reasonable to obtain an EKG. But a routine EKG for all patients, regardless of their risk, is not recommended. Now, the timing of when you want to get an EKG on these patients is not really well decided, but there's a general consensus. If you can get an EKG within 1 to 3 months' time of the surgery and there's no clinical change in the patient, you're okay with that EKG. Now, we usually assess the LV function with an echocardiogram, and it is reasonable if you see a patient in the office and you figure out they have dyspnea, but their lungs sound clear, they don't have severe COPD, and you're not really sure about their LV function, it is reasonable to get an echocardiogram before they go for a surgery. Somebody with established congestive heart failure and they have a change in their clinical status, it's a good idea. You want to figure out if there's been a change. But somebody who has established LV dysfunction, which is typically noted to be less than 40%, and they haven't had an assessment over the last 1 year, it is a good idea to reassess them with an echocardiogram. But a routine screening of all patients going for any surgery is not recommended. It's a class 3 recommendation. Now, their ECG is a fairly useful tool, especially for patients who have underlying coronary artery disease. It has prognostic value. However, there are certain limitations when patients have baseline EKG changes that make it hard to assess the EKG for ischemia. Left bundle branch block, left ventricular hypertrophy with strain changes, patients who take digitalis, digoxin, they have baseline EKG changes that make it harder to assess them just on the EKG. So for these patients, an additional imaging modality to risk stratify them is recommended. Now, let's quickly talk about the role of coronary revascularization before surgery. So the guidelines recommend that the patients should go for coronary revascularization just before surgery, just as they should go without a surgery. So if you're seeing somebody in the office and they're going for a surgery, you should not just work to send them for cabbage or put a stent just to decrease the risk of surgery. You should assess them. If their symptoms are stable, they might be medically managed. And it's not, what they found out is most of the perioperative deaths, they are related to unprotected left main disease, severe 3-vessel CAD, and proximal left anterior descending artery disease. So if you have anybody with that kind of underlying coronary artery disease and they are going for a non-emergent non-cardiac surgery, it may be a good idea to revascularize that before sending them for surgery. The role of PCI before surgery is limited. You don't want to do a coronary intervention, which is essentially a controlled plaque disruption in somebody who's going to be exposed to a more inflammatory milieu in the postoperative period coming up soon. So it should be done for patients who need it, for unstable angina, for MIs, but just to decrease the risk of perioperative MIs, it's not recommended. And this recommendation is based on a large randomized controlled trial, which was a CARD trial published in New England Journal of Medicine in 2004, which showed that patients who were undergoing high-risk vascular surgery were randomized to people who got revascularization done and people who were just medically managed. And they were followed for perioperative events and a long-term follow-up. And except for these exceptions of patients who had left main disease, less than 20% on their EF or severe aortic stenosis, there was no significant difference in both the groups. Now let's briefly talk about the perioperative medical management. Antiplatelets, beta blockers, and statin therapy. So it's a class 1 recommendation for any patient who's had a stent put in to have a good communication between the cardiologist, the anesthesiologist, and the patient included, and the surgeons, so they understand what the risk of bleeding is if antiplatelet therapy is not interrupted, and what the risk is of stent thrombosis if we do interrupt it. So this is an algorithm from the guidelines that looks at that. So if somebody has a stent, you really don't want to take them to surgery within the first 4 to 6 months, if at all possible. Even if you have to proceed with an elective surgery, you have to ask this question. Does the patient have a really high risk of bleeding, which is going to be too high even if they risk stent thrombosis? If not, they recommend you continue both the dual antiplatelet therapies, which means aspirin, and in addition Plavix or Brilinta or Effient. Now, once you get to beyond a 6-week time and you are not dealing with a bare metal stent, because bare metal stents are usually fine in a 4 to 6 periods, if you have to interrupt the P2Y12 inhibitor, then it's still recommended that you continue your dual antiplatelet therapy uninterrupted up to a full year if the patient has to have surgery, or delay the surgery till they can be completed. Beyond a year, you obviously can stop the P2Y12 without much concern for stent thrombosis. Now, the beta blocker story is a little bit interesting because all of us have this ingrained in our minds from data that we've heard over many years that beta blockers are beneficial around the time of surgery. And this is largely based on the decrease trials. There have been a bunch of decrease trials, decrease 1 to 5, and the primary investigator on all of them was Dr. Don Polderman. He was a cardiovascular researcher based out of Netherlands, but in 2011, his research came under scrutiny from his own institution where they were not sure about his research practices, and a lot of that data was retracted because the outcomes were far better than other researchers was showing. In addition, there was also the POISE trial that came out, which was assessing patients who were put on beta blockers on the day of surgery at pretty high doses. And this showed that the outcomes were actually worse. PAUSE trial showed that if you put patients on high-dose beta blockers on the day of surgery, they have higher risk of death and stroke. So a blanket beta blocker treatment is not recommended. What do the guidelines say? They say continue beta blockers who are chronically on beta blockers. It's actually a class 3 recommendation to stop it just before surgery. Guide beta blockers as clinically directed. If somebody is having hypotension, bradycardia, decrease the dose, hold the beta blocker. Somebody has AFib, you add the beta blocker. It is reasonable to start a beta blocker in patients who have high risk perioperative test findings. And if somebody has a high revised cardiac risk index score, it is a reasonable option to start them. But the important thing is it should not be started on the day of surgery, preferably 1 to 2 weeks before. Now statins, we've heard Dr. Singh, it's a magic drug. It has great outcomes for people who have established CAD or peripheral vascular disease. There's a 30% relative risk reduction in MACE if you put patients on statins going into surgery. So what do the guidelines recommend? They recommend you continue people who are taking them perioperatively on statins. Patients who are going for vascular risk, they actually say it's a class 2A recommendation to start them on statins. And for patients who have high clinical risk factor profile, it is also recommended you put them on statins. So I try to compress everything in a short talk, and then we'll finally end with the sample case that I'll put forward to my panelists here. So we have, and let's see how they risk stratify or how they suggest we do it. A 66-year-old male veteran who's being evaluated prior to a sigmoidectomy, secondary to a non-metastatic adenocarcinoma. He's obese. There's past history of hypertension, dyslipidemia, non-obstructive CAD, recent heart failure hospitalization, COPD, and a non-insulin dependent diabetic. He quit smoking 2 years ago. Functional status is limited, family helps with ADLs, has poor exercise tolerance, lab and EKG look fairly normal. So, Dr. Vaishas, how would you look at this patient?
Well, there are certain considerations that come to mind. First of all, he does have, he's going for a sigmoidectomy for non-metastatic adenocarcinoma. So you have some time, and it's not a really high-risk surgery overall. In terms of his coronary artery disease risk, he does have a history of non-obstructive CAD, which we don't know from the case here whether it was recently diagnosed or it was an historic diagnosis. But be as that may, I'm assuming that he has, what you're suggesting is that he has non-ischemic cardiomyopathy of some sort, CHF. One thing which I would want to know would be what his overall ejection fraction is in terms of where he is, and if this CHF was the first diagnosis of CHF or he's chronically has had CHF as a diastolic dysfunction. So I would want to know more of that, and certainly it sounds like his overall exercise capacity is limited overall. So I would probably want to know at least a little bit more. And the point that you alluded to, which the guidelines actually stress, is that you want to take care of these patients as if taking the surgical component out of the case mix. So this patient just presented to you and you didn't have the first line. I think what would you want next?
Absolutely.
And so I think that would be my next question to you would be as to where we stand with that.
Absolutely agree with that. Thank you. Now I'm going to open the floor for any questions if there are any.
Can I point out something? His dyspnea and exertion may be an anginal equivalent because he's on insulin, and that's a case you have to think that is this patient really having angina? So I'd be concerned with this patient. I do agree we need to look at whether or not this is systolic versus diastolic heart failure. So an echocardiogram would definitely be indicated in this patient before going to surgery, and a pharmacologic stress test as well because he will not be able to exercise.
Great. I hope all of you are as well versed in this as they are now. So that's what I expect. Thank you.
So Dr. Akbar, what is the answer? What did you do for this patient?
It was an open. That was a hypothetical question, I guess. But that was a very good job done, Dr. Akbar. He covered everything very comprehensively. Next, I would like to invite Dr. Dawson. She would be moderating the next session, if there are no more questions for Dr. Akbar.
Any other questions for Dr. Akbar?
I think one of the comments is about, I think it was a great presentation. One of the things that is written as a subtext in the guidelines, and I think goes a long way, is having a direct verbal communication with the surgeon. And especially cases that are simple and you can stop or hold the antiplatelets is simple, or someone you don't want to hold the antiplatelets, but oftentimes there's a gray zone. And I found out that sometimes the surgical colleagues are resistant in doing the surgery. But when you just pick up the phone and talk to them and tell them, there's a high risk of stent thrombosis, or you're really nervous about that, and I think you can usually come to a solution. So I would definitely say that risk assessment should include a communication, at least in those cases, because that, I think, can benefit the patient a lot. And secondly, for those of us who do write risk, do these risk evaluations, I would also suggest that we get over this mindset of clearing the patient for surgeries. It is really a risk assessment, and it is the idea is to mitigate the risk. That thought process has to change and be as concise in terms of your recommendations. I mean, if you write 10 recommendations for the surgeon, they're unlikely to follow everyone. I think you should just concentrate and focus on the ones that are most likely to mitigate the risk, but mostly to provide a risk assessment and have a verbal communication.
Yeah, I think I would like to re-emphasize what Dr. Washi said, because I think up until a few years ago, we were all saying patient cleared for surgery. So as per the new guidelines, we should not mention that word at all in the chart. It has legal implications. So when you're seeing someone preoperatively, whether it's an internist or a cardiologist, you assess their risk prior to them going to surgery. So you're never clearing a patient pre-op. You're just assessing their risk for that surgery. Right, we'll move on to the next session then.
Yes, one question.
Oh, sorry.
One other quick comment along those lines, though, and I'm glad you brought up the idea of like clearing them for surgery, and because the other issue though is who tells the patient, because there still is a huge gap, because even if you're doing risk assessment and you talk to them, the issue is who explains to the patient, though, it doesn't mean there's zero risk, because frequently the patients don't understand this complex assessment, whether it's a general surgeon or a thoracic surgeon or whatnot. They may or may not have explained it to them. And even though their risk may only be 2 or 3%, the family does not understand it afterwards then when they have an acute MI or some other event. And it's also very important is who actually explains that risk assessment to the patient and what it means, because that also gets left behind frequently as well.
Yeah, and I think that point's well taken, because I think the onus really lies on the cardiologist or the medical team that is providing that service, that they should discuss with the patient and communicate it to the patient as well as the surgeon. And I think low risk is not no risk. I mean, the chances are that you will get by without any problems. And that's the same thing when I tell the patients with the stress test, when they have a normal stress test, it doesn't mean you have zero risk. It just means you have low risk. So I think your point's well taken.
Do you guys also recommend that the cardiologist should ideally do the assessment, or does not matter? Give out the guidelines.
I personally don't think that it is necessarily the domain of only the cardiologist to make this call. I work and I've seen many fantastic colleagues in medicine who actually make a great call. They are actually better suited in many times because they have a longitudinal relationship with the patient. They know the history better. Oftentimes it's a consult. But I think there should be an avenue where if there is any doubt, then they should be able to reach out to the cardiology colleagues. I don't think you can stipulate that only cardiologists can do these type of risk assessments. I think if an internal medicine physician, nurse practitioner, PA feel that they are adequately qualified and can do it, then I think all the power to them.